Okay, welcome everybody to our webinar this evening. My name is John Hardgrove. I'm a project manager here at APNA and I'm your facilitator for this evening. And this chronic kidney disease webinar has been developed as part of APNA's Chronic Disease Management and Healthy Aging program. I'd like to start with an acknowledgement to country. APNA recognises the traditional custodians of land and sea on whose lands we work and live. We wish to pay our respects to all traditional owners and elders, past, present, and future. Just a quick speaker disclosure statement that Kidney Health Australia primary care workshops are presented by volunteer speakers, nephrologists, renal nurses, and other health professionals. And APNA has modified this presentation with the permission of Kidney Health Australia to fit the context of general practice nurses and aid in their learning. So our learning aims for this evening is to provide the tools to drive the early detection of chronic kidney disease in a primary care setting using optimal management of CKD with the aim to halt or slow disease progression. Some of the learning outcomes are to understand the causes and pathophysiology of the development of chronic kidney disease, to identify people at risk of developing CKD, to know the screening tools and opportunities available for nurses in general practice, and to be able to support people with CKD through patient-centered care. So at this point, I'd just like to introduce our speakers for this evening. We're joined by, firstly, Annette Bazant, who's a nurse practitioner at Monash Health Nephrology. Annette works as part of a multidisciplinary team at Monash Health to ensure patients across the spectrum of chronic kidney disease receive timely and effective care. Her role includes autonomous and collaborative care with a strong focus on education and patient self-management. She has a special interest in improving the patient care journey for people living with complex comorbidities of diabetes and kidney disease, as well as caring for pregnant women living with advanced kidney disease. And our second speaker is Jacqueline Isles, who's a practice nurse at Jindabyne Medical Centre. Jacqueline graduated from Newcastle University. She holds a postgraduate certificate in perioperative nursing and is an authorised nurse immuniser and rural X-ray licence holder. She's a founding member of the Wednesday Room Clinic in Jindabyne, as well as working at Element Skin Clinic. She's an active community member in the Snowy Mountains region of New South Wales, where she was awarded Citizen of the Year in 2016 for her volunteer work in the community in relation to sexual health and mental well-being. She's currently studying to increase her knowledge in skin cancer care. And finally, our last speaker, Lani Hewitt, is a coordinator for the regional renal program at Miwatch Health. Lani has been working in Aboriginal health for the past 7 years, mainly in the field of chronic kidney disease management within a primary health care setting. She enjoys empowering patients to take control of their health and supporting them on their health journeys. Although it is very challenging and successes can be small, every person does count. She enjoys spending time with her family, and with 3 boys, that involves quite a lot of sport and food. So just before we get too far into it, we'd like to start off with a quick poll just to understand who we have in the audience out there. So you should see a poll launching up shortly. And you can feel free to choose your registration status. You can pick more than one. And then also just choose the setting which best describes your place of work. So far, it looks like we've got quite a few registered nurses. 75% of people so far are registered nurses, 13% are enrolled nurses, 13% nurse practitioners, 4% practice managers, and 58% of you coming from a metropolitan setting, 29% from a regional setting, 12% from a rural setting, and 4% from a remote setting. That's great. Couple of results still coming through. Yeah, so still sitting at about 69% of registered nurses, 14% enrolled nurses, 10% nurse practitioners, 7% practice managers, and the bulk of you are coming from a metro or regional area. So that's great. I will now hand you over to Lani to start the presentation.
Hi, welcome everyone. So chronic kidney disease, also known as CKD, what is it? CKD is defined as a loss of kidney function or evidence of kidney damage that lasts for 3 months or more. Kidney function is measured using a formula that estimates the glomerular filtration rate from a blood test, and anything less than 60 mils a minute is considered CKD. Kidney damage is identified by the presence of albuminuria, hematuria, structural abnormalities, and pathological abnormalities. CKD in itself is not a diagnosis, and attempts should be made to identify the underlying cause. The major cause of kidney disease in Australia is type 2 diabetes mellitus, followed by hypertension. Other causes include glomerulonephritis, polycystic kidney disease, and some rare autoimmune diseases like systemic lupus erythematosus. CKD is a silent disease. Up to 90% of kidney function can be lost before symptoms present. Some early signs and symptoms include tiredness and lethargy, upset stomach, nausea, but eventually CKD will cause changes to all of the normal functions of the kidneys. So it will affect control of body fluids, filtering of waste products from the blood, stimulating the production of red blood cells, regulating the blood pressure, maintaining the sodium balance, controlling potassium, calcium, and phosphorus levels, and regulating vitamin D. So next slide, kidney disease in Australia. So 1 in 3 people are at an increased risk for CKD. 1 in 10 will have CKD, and less than 10% of those with CKD will know they have it. 1 in 1,400 are on a renal replacement therapy, either hemodialysis, peritoneal dialysis, or living with a transplant. Kidney and urinary tract diseases are the 9th leading cause of death in Australia. So as we can see on the pyramid here, we have 5+ million people at risk for CKD, with hypertension and diabetes being the biggest risk factors. And less than 10% of those people with CKD are aware that they have CKD. And 25,000 up the top that are on some form of renal replacement therapy. So who's at risk for CKD? 1 in 3 Australians are at risk for CKD. Anybody with diabetes, high blood pressure, heart problems or stroke, family history of CKD, obesity, smokers, over the age of 60, Aboriginal and Torres Strait Islander people, and a history of acute kidney injury. Some of these are modifiable and some are non-modifiable risks. Things like age, family history, race can't be modified. And this is where the primary healthcare can help support people to modify their risk factors and also identify people who are at risk. We should screen opportunistically and strategically for risk evaluation, but also be creative to invite people to come into the practice and be screened. Next slide, CKD in Aboriginal and Torres Strait Islander people. So Indigenous Australians have an increased risk for CKD compared to other Australians. They are 5 times more likely to have end-stage kidney disease and are diagnosed with end-stage kidney disease at a younger age. 2/3 are diagnosed when younger than 54 years of age. They're more likely to die from CKD between the ages of 45 and 54. And the causes of this gap are complex and include differences in social determinants of health, risk factors, and access to appropriate healthcare. Repeated infections, high blood pressure, obesity, low birth weight, diabetes, engagement in high-risk behaviours adversely affecting health, like poor diet, low activity levels, alcohol and tobacco use, and infant and in utero malnutrition all contribute to their increased risk. To provide a little more context around this, in the NT, in the last 4 years, there has been a 52% increase in type 2 diabetes in Indigenous people between the age of 15 and 25 years. It is thought that epigenetics and intergenerational disease plays a role. Mothers with uncontrolled diabetes in pregnancy predispose their children to excess adipose tissue, and this, in combination with social and lifestyle risk factors, increase the risk for type 2 diabetes at a younger age. 20 years after a 15-year-old has been diagnosed with diabetes, we are seeing a 35-year-old mother who needs renal replacement therapy, most commonly hemodialysis in the NT. These are some scary stats. Why do we want to slow progression? Well, kidney disease is a major public health problem. It is in the top 10 causes of death in Australia and kills more people than road deaths, prostate and breast cancer. In 2017-18, CKD accounted for 16% of all hospital admissions. That was 1.8 million hospital admissions, of which 80% were for dialysis. In remote areas, the hospitalisation rate is 2.7 times higher, not including admissions for dialysis. CKD is also preventable and manageable. Early detection and appropriate treatment can slow and even halt progression. If we look at the slide here, we can see the black line is a late referral and the red line is effective interventions and management, which leaves with residual renal function, and possibly they won't need renal replacement therapy. Early detection and timely appropriate management of CKD, especially with respect to blood pressure control, will substantially reduce kidney failure progression and cardiovascular risk by up to 50%. So how do we detect CKD? With a kidney health check. This consists of a blood test, a urine test, and a blood pressure check. GFR is accepted as the best measure of kidney function, gold standard. It is measured using a blood test for serum creatinine and shows how well the kidneys are functioning. GFR is estimated from serum creatinine using prediction equations. This gives an estimated GFR. eGFR is shown on pathology reports, normally with electrolytes like potassium and sodium. Anything greater than 90 mils is considered normal. And as we age, our eGFR will decrease. So unless there are any other pathological or structural abnormalities, an eGFR between 60 and 90 is not considered CKD. Below 60 is and requires further investigation. The ACR check is for the presence of protein in the urine. Excuse me. The most common being albumin. Albumin is normally too large to pass through the kidney's filtering system into the urine, so it indicates that there is damage occurring to the kidneys and accurately predicts renal and cardiovascular risk. Other factors that increase ACR results and should be excluded include UTIs, high protein diet, congestive cardiac failure, acute febrile illness, heavy exercise within 24 hours, and some drugs. Hypertension is a cause of kidney disease and also can be seen as a symptom of kidney disease. It is also a risk factor for cardiovascular disease. Maintaining optimal BP control is an important goal in management of CKD. We should target high-risk groups and implement a recall system to keep track of patients. Now I'll hand over to the next speaker.
That's me. I'm Annette. I hope you can all hear me. Good afternoon or good evening from wherever you are. So once you've done your kidney health check, you can use the results to help you to stage the CKD. So in other words, the kidney health check allows you to appropriately define and manage the stage of CKD once the actual presence of the disease has been confirmed. So for example, a female with 30 milligrams per millimole of albuminuria with a GFR of 35 mils per minute comes within the orange action plan, and the CKD management book, which has these colour-coded plans, will help you to work through the various management strategies. These come under the green, yellow, orange and red traffic light type of system, and we'll go through what some of those management strategies are as we work through the slides a little bit further. Overall, the aim of these management strategies are to reduce the overall risk of the progression of the chronic kidney disease, to reduce the risk of cardiovascular events as well, being the main mortality risk in this patient population. Next slide, thanks. So the major role of the kidneys is to filter the unwanted substances from blood and produce urine to excrete waste and excess water. So blood enters via the renal artery and it passes through the structures called the nephrons. Each kidney contains around 1 million nephrons, and each nephron is comprised of a glomerulus, which is enclosed within a cup-like structure called the Bowman's capsule, and a renal tubule. And there's three main steps to urine formation. The first step is glomerular filtration. This is when blood flows into the glomerulus and the blood pressure pushes water and solute from the capillary structure into the capsule through the filtration membrane. This membrane allows water and small solute to pass whilst blocking the passage of blood cells and large proteins from leaking through. The next stage is tubular reabsorption. And this is when the filtered waste containing substances that the body needs, such as glucose, small proteins, amino acids, and other essential ions, the substances that are needed by the body are reabsorbed from the tubules back into the peritubular capillaries. And the final stage of urine formation is tubular secretion. So the unwanted water and the hydrogen ions pass from the capillaries back into the tubules, and the remaining filtrate becomes urine. So urine is 95% water. The other components are creatinine, urea, ammonia, uric acid, salts, and other ions. Urine flows out of the tubules into the collecting duct, out of the kidney, through the renal pelvis, into the ureter and down into the bladder. And it's stored in the bladder until it's eliminated from the body via the urethra. So along with filtering the waste products of metabolism, the kidneys help to keep electrolyte and water balance in the body constant, and the clean blood is returned to the body via the renal vein. Next slide, thanks. So most causes of kidney disease, including diabetes and hypertension, cause damage to the nephrons, impairing the ability of the kidneys to filter the blood effectively. The first sign of kidney damage is the presence of protein in the urine, also known as albuminuria or proteinuria. The glomerular filtration rate estimates how well the kidneys are working, and it's an indirect measure of kidney function using creatinine. The filtration rate is dependent on how many nephrons are available and how well they're filtering, and also how much blood passes through the nephrons. So normally kidneys filter up to about 200 litres of fluid in a 24-hour period, and most of that filtrate is reabsorbed with approximately 1 to 2 litres per day excreted as urine. The glomeruli are a tight bundle of blood vessels inside the Bowman's capsule, and the high pressure caused by hyperglycemia or hypertension, for example, increases the pressure within the glomerular structure. The increased pressure weakens and damages the filtering membrane, and this leads to the albumin leakage into the filtrate. The increased pressure also causes thickening and stiffening of the capillary walls. So too little pressure, there is not enough kidney perfusion, and too much pressure causes damage. We now also know that increased pressure causes upregulation of the SGLT2 channels that are located on the proximal convoluted tubule. And these channels allow for reabsorption of glucose and sodium into the bloodstream. And hence, these are the latest targets for treatment to slow progression of kidney disease. The kidneys, like the pancreas, work harder to maintain homeostasis, but eventually they do wear out and normal function is lost. Once kidney function in chronic kidney disease is lost, it's irreversible. And this is why tight control of blood glucose levels and blood pressure and other targets are really important goals of managing kidney disease. Nephron numbers may be reduced due to smaller sized kidneys, tissue death, transient causes of acute kidney injury such as kidney stones, medications, glomerular nephropathies, or pyelonephritis. Next slide, thanks. Sorry, I just wanted to go back to the previous slide and mention one other thing, sorry. So the other important job of the kidneys is to secrete and activate hormones, including erythropoietin, to increase the production of red blood cells in the bone marrow, renin to assist in blood pressure regulation, activation of vitamin D to maintain normal blood calcium levels and support strong bone health and effective muscle function, and phosphate excretion and reabsorption. So urea and creatinine are the two major metabolic wastes that the kidney excrete. Urea is the final product that's produced from the breakdown of amino acids that make up proteins. The liver converts metabolized amino acids to ammonia, carbon dioxide, water, and energy. And ammonia is toxic, so it must be excreted. So the liver converts the ammonia to urea, which can then be excreted safely via the kidneys. Creatinine is the waste product of creatine, and creatine is used by the body to supply muscles with energy. As muscles use energy, the tissue breaks down and releases creatinine into the bloodstream. Creatinine is perfectly normal, and the more muscle that a person has, the more creatinine they produce, and a healthy kidney can filter this efficiently. But when kidney function is impaired, the filtration of creatinine is also impaired and the levels accumulate. Creatinine is used as it's very easy to measure, and it's increased via the kidneys in an unchanged state. Next slide, thanks. The renin-angiotensin system plays an important role in regulating blood volume and systemic vascular resistance. There's three components to the system, and these are renin, angiotensin, and aldosterone. So step one in the system is when renin is released primarily from the kidneys. Step two is when renin stimulates the formation of angiotensin into blood and tissues, And step three, when angiotensin stimulates the release of aldosterone from the adrenal cortex. So just to explain that in a bit more detail, renin gets released in response to a reduction in afferent arterial pressure or a reduction of the renal blood flow, which might be caused by sympathetic nerve activation or renal artery hypotension, or decreased delivery of sodium to the distal tubules with the feedback mechanism that goes on. The plasma renin converts angiotensin released by the liver to angiotensinogen released by the liver to angiotensin. Angiotensin is converted to angiotensin 2 by the angiotensin converting enzyme, which is released predominantly from the lungs. Angiotensin 2 causes blood vessels to vasoconstrict, and this increases blood pressure. Angiotensin 2 also stimulates the release of aldosterone. Aldosterone causes the renal tubules to increase reabsorption of sodium, and this reabsorbs water into the blood. At the same time, potassium is also excreted, and this process ultimately increases blood pressure also. So patients with proteinuria and diabetes should be treated with ACE inhibitors or ARBs as their first line treatment. ACEs and ARBs are associated with a reduction in albuminuria and improved outcomes. Whenever we're starting an ACE or an ARB, a reduction in the eGFR is expected, and anything less than 25% within 2 months is an acceptable reduction range. Potassium levels do need to be monitored with targets aiming at less than 6 millimoles. And certainly if a patient is demonstrating levels of greater than 6.5 millimoles, this is putting them at risk of a cardiac arrhythmia, and they should be referred to the emergency department. There are certain medications that need to be used very cautiously in kidney disease, and one such combination would be the triple whammy, which is a combination of ACE or ARB in combination with diuretic and non-steroidal anti-inflammatories. These can cause an acute kidney injury. So avoidance of non-steroidals is particularly important in these patients. Next page, thanks. So bone abnormalities are common in chronic kidney disease. As kidney function declines, there is a progressive deterioration in mineral homeostasis. The mineral and endocrine disruption alters the concentration of phosphate and calcium and the circulating hormones. Phosphate excretion is diminished as early as stage 3 CKD, and this leads to hyperphosphatemia. Hyperphosphatemia leads on to reduced vitamin D conversion and hypocalcemia. The body seeks to normalise serum calcium levels by increasing the parathyroid hormone. And the parathyroid hormone normally promotes phosphate excretion and the gut calcium absorption, but in chronic kidney disease, the kidney fails to respond appropriately. All of these processes are vital to bone formation, growth, structure, and function. And as a result of the disruption, bone abnormalities develop and can lead to things such as extraskeletal calcification and deposition of soft tissue, including blood vessels. So what this means is the laying down of bone in blood vessels and soft tissue. Pruritus occurs as a direct result of hyperphosphatemia and toxin accumulation. And there are several medications that are used to try and mitigate the effects of what's known as chronic kidney disease mineral bone disorder. But the dietary interventions are also vital to reduce dietary intake of phosphate to help slow this process from occurring. Next page, thanks. So anemia is a reduction in the oxygen carrying capacity of the blood due to a reduction in red blood cell mass. It's indicated by a decreased hemoglobin concentration. The prevalence of anemia increases with a reducing glomerular filtration rate. It is very common when the GFR falls below 30 mils a minute. The first symptoms of anemia, such as fatigue, weakness, shortness of breath, pallor, dizziness, can in fact be the first symptoms that a patient may experience of their chronic kidney disease. So what happens in this process? The precursors to all blood cells are found in the bone marrow. And erythropoietin is the hormone that regulates blood cell production. It's primarily produced in the kidneys. In the setting of hypoxia, the kidney is stimulated to produce EPO. This then travels to the bone marrow to stimulate erythropoiesis or red blood cell production. Erythropoiesis increases the amount of circulating red blood cells. Increased tissue oxygenation then inhibits EPO secretion as levels of hemoglobin return to normal. When chronic kidney disease is present, EPO production is decreased. There's also dysregulation of iron storage and other inflammatory processes going on, and this all contribute to the presence of renal anemia. Untreated anemia can certainly have a negative impact upon cardiac function, cognitive function, physical function, and quality of life. It's a very common comorbidity of chronic kidney disease, and it's important to identify and correct. There's very strict criteria regarding the use of erythropoietin agents to correct anemia. They cannot be started until a hemoglobin falls below 100 grams per litre, and a nephrologist does require the authorisation to commence the medication. It's important to also remember that hemoglobin targets are lower for people with chronic kidney disease than that for the general population. So in a person with kidney disease, we're actually targeting a range of 110 to 120 grams per litre. If we try to achieve the target that is as for a normal person without kidney disease, then we can cause adverse health consequences for them. Many of the patients will self-administer the medications. It's a subcutaneous injectable medication, but many you will find present to your practice for support to give that injection. Depending on the agent used, injections may be needed to be given anywhere from once a week to once every month, according to how the patient's responding. And there's storage considerations that vary between the different agents, so always be sure to read the product information. Due to dysregulation and increased utilisation of iron stores, most of these people will also require IV supplementation, and oral iron is usually insufficient. High doses are needed and it's intolerable for the patient, and so IV iron is usually administered either in your practice setting or in the day treatment setting. Next slide. And I'm handing over to somebody here.
You're just on mute, Jackie.
Hi everyone, I'm Jackie. I'm coming to you tonight from the Snowy Mountains region of New South Wales. I don't have a lot to do with chronic kidney disease per se, and what I do as a registered nurse here in the Snowy Mountains doesn't include care planning for chronic disease. I've really enjoyed the information shared by both Lani and Annette tonight, and it's been an eye-opener for me. I more have opportunistic moments to catch these types of chronic illnesses with people that are here on holiday or for short term. So I hope you've got a lot out of this evening, and I can share the types of things that I do within my general practice setting. And I do encourage you to ask a few questions, even if that's about how would you pop questions into your day with a client, what your experiences are, because we're all here to learn and grow and change together. So for my section tonight, we're starting with the big challenge, which is lifestyle changes and how we can empower our patients to take control and self-manage. That will be something that's quite different in every setting of nursing and primary healthcare, depending on what you do and how you do it, your relationship with the GPs or doctors within your practice, if you're in a rural or city location. So that's a very varied thing. And I do encourage you to pop into the chat box, anyone that's feeling brave enough, different ways you have of contacting patients, making first contact, using that opportunistic moment to get a urine test, get blood screening done, if it's part of your usual review that you do with clients as part of care planning. Do you offer screening processes to people with a family history, and how you engage your client base? Because I think it's a really good chance now to share what we do and how we do it, so other people can pick up tips and tricks. The SNAP guidelines from the RACGP and the motivational interviewing advice in the RACGP Green Book give us a tool on how to approach behaviour change, and how we can measure that, and how we can have those open conversations in a respectful manner. So I do encourage you to, once this is finished tonight, maybe if you've still got a little bit of energy, to Google the RACGP Green Book. SMART goals are usually applied in formulating care plans, but you'll all have your systems and policy and procedure, whether that's within medical director or best practice, or perhaps a tool you've created yourself. And I would also encourage you to share that on the APNA page, or if there's anyone here this evening from the TPP program for new graduate nurses, if you'd be happy to share your questioning and policy procedure and what you follow to engage people and how you formulate your care plans, because APNA is a community of learning, growing and sharing. And then of course, are we listening to the patient and what their wants, needs, desires and area for education is. John, is there a link that we can click on there to It's Not About the Nail?
Yeah, so we'll be able to share these slides and the recording after the session as well. So we'll be able to get those out to you so you can follow up on that link.
Beautiful. We might go to the next slide then. So just recapping a little bit of what Lani and Annette have shared with you all this evening, and I guess mostly something that we can all do with every client that comes into our care, and I certainly can, even when someone comes in for a fracture off the mountains, we're probably going to check a blood pressure anyway, but a good place to start, and when you're taking that person's history outside of the immediate event with which they've presented to you for today, we can always check a blood pressure. And for all people with chronic kidney disease, we want to maintain that blood pressure below 130/80. Looking at weight reduction and targets there, which is right up in front of you. So BMI target of 18 to 24.9 kilograms. As you can see it all in front of you there, dietary salt restrictions, the DASH diet, which including fruit, vegetables, saturated and total fats, physical activity between 30 and 60 minutes of aerobic activity 3 to 5 days a week. And perhaps there's exercise physiologists within your community that people can connect with, or other community events. Where I am in my rural location, that although it is a tourist town, we do get quite quiet outside of seasons. It's nice to stay really connected to your community and find innovative ways to engage with people, to educate people, and also encourage a lifestyle of health and wellness. So you might even turn up to the walking group yourself, or your local park run, get involved through community centres or your local neighbourhood centre. And then the last point, they're looking at moderate alcohol consumption. So for men, 2 drinks a day, and for women, 1 drink a day. And we might just go to the next slide, please, John. Cardiovascular disease risk in chronic kidney disease, as Lani and Annette have both touched on in far more detail than me earlier. We see these things together. Patients with chronic kidney disease are 20 times more likely to die from cardiovascular events than to reach the stage where they actually receive dialysis, which is quite a shocking piece of information for someone like me that's not highly involved.
Looks like Jackie might have just dropped out there, and we'll give her a second to see if we can get her back online.
I think I'm back, John.
Okay, great.
We have a bit of snow loading and a lot of winds tonight, so I'm very sorry. I just go to that next slide. Hopefully, you can drop out there at the end where I share the information on patients with chronic kidney disease are 20 times more likely to die from cardiovascular events and survive to reach their dialysis. I'm not sure if I was still connected there. And just the next slide, please, John. So if we look at chronic kidney disease, diabetes and heart disease, often these 3 things are seen together, which I have mentioned earlier this evening. Relationship with each one can cause us as a combination of and sometimes difficult to see what started there. And think of all 3 of these systems and conditions every single time you care for one. Keep the other 2 in mind. And just the next slide, please, John. Looking into nutrition and chronic kidney disease. So follow those dietary guidelines. That's important for us to have. Find importantly when I'm dealing with something that's new to me, those guidelines are there for a reason. They're to help to support and educate us so that we can support our clients in the best way possible to help them reach their ultimate health views for themselves and the things they will stick to that they find helpful for their own lives. Advise a person, of course, of that salt restriction, normal fluid intake, including water, aim for a normal BMI, as we went through before, and a dietitian referrals recommended if the eGFR's over 30. Malnutrition is a very common thing. So if you have access to those services within your community for a dietitian, always better to start sooner rather than later, even if it's just information on where to contact this person should things change. And within rural communities, don't forget the telehealth capacity and have a look at what the options are for you and your clients. We might just go to the next slides if everyone's going to receive the slides. The nutrition information. Thank you. The medications. The aim is in protecting the kidneys, as Annette said earlier, to further avoid damage from high blood pressure. So diuretics, RET inhibitors, ACE inhibitors, ARBs, aldosterone antagonists, vasodilators, calcium channel blockers, beta-adrenergic receptor blockers. So they'll be rattling down the street like a packet of Smarties at times with the list of medication. It's important that when we're providing information on those medications, if we're not familiar with them ourselves, to share with our patient, get in contact with the pharmacy where the patient will be getting their medication from and make sure they have a printout of their medications, that all your stuff's up to date within your notes and on the patient file, for them to be uploaded to my health record. And I always think in a rural community such as mine, it's good to have a good working relationship with the professional people that your client might be involved in. So I have a good working relationship with our local pharmacist. Sometimes we'll even walk the client to the pharmacy to make sure they feel comfortable with the information they've received, and I learn something too. So I do find getting involved when you have the time to really people's education and feeling like you really do care for them. So we might just go to the next slide, please, John. So managing chronic kidney disease in the primary healthcare setting. So we're looking at preventative care a lot of the time, which is fantastic, but often I know within my workplace setting, we're picking things up rather than preventing things. So I guess we want to provide education and just help the person with an understanding through the disease process and maintaining their best state of wellness. Using your audit tools, recalls and reminder systems that you have in best practice medical director or system it is that you're using in your practice. Doing regular kidney health checks and screening. And as I said earlier on, have a look at those different ways that you engage with your clients and your community. Often the nurses where I work are happy to go out and do community education because that works a little bit better in our community, to go to the schools and have a chat, the neighbourhood centre, community centres, the local memorial hall. WA has often hosted us for information sessions on health, which has been a really good way to connect to our community as well. You'll, of course, will have your planned care and your management plans, as well as TCAs. We bring up the reviews and follow-up services that the client is eligible for as well. I have touched on already the multidisciplinary care, optometrists, dentists, physio, nephrologists, psychologists, and then again, depending on your community, rural location or city locations and that capacity for telehealth, especially within these COVID times. Always important to have patient-centered care because the patients are expert in their own health, and you can make all suggestions under the sun, but if it doesn't suit that person's lifestyle, family, or their capacity to attend those appointments, especially if it's a rural location and travel becomes a little bit difficult, always best to check with the client and their family and their support capacities. It'll give you a gauge of potential compliance with the care plan that you've put together. So next slide, please. So in conclusion to all the information that we've all shared here this evening, and again, I do encourage you to start clicking away in the little box before we all go to bed for the night if you've got any questions. Early chronic kidney disease is common and can primarily be managed in a primary healthcare setting. The therapy overlaps significantly with best practice in cardiovascular risk reduction and diabetes care. So our beautiful diabetes nurses out there, anyone doing their healthy heart checks within their practice and receiving for that, let's step it up and do the best we can for our CKD clients as well. Thank you.
Thanks for that, Jackie. We had a couple of instances where your voice was cutting out there just due to the connection issues, but hopefully that came across for everybody in the audience. If you did have any questions and you wanted us to cover back on any of that information, feel free just to give us a shout out. We can always back up to one of the slides and go back over that again if that's of help to anyone. Someone has just asked in the Q&A if we will have access to the recording of this webinar, which you will. We'll be sending you out recording of this session today as well as the slides, so you'll get access to those materials. And while we wait for any other questions to come through, we might just launch a quick poll just to sort of cap things off. Just bringing that poll up now. Bear with us while we sort through the technical difficulties. There we go. So just curious to know how satisfied you were with tonight's content and speakers. Be great if you can give us your honest feedback. We do take that into consideration when we're producing these webinars, and it's always good to hear from the audience and see how things are going. Got quite a few votes coming through, so I'll just give you guys a little bit longer to go ahead and vote. And once you've voted, if you do have any questions, feel free to type those out. You can feel free to use the chat question, or feel free to use the chat bar if you'd like. Otherwise, the Q&A function is there. No questions coming through. Looks like we have a satisfied audience. Well, on that notice, if we don't have any questions that people want to ask, I'll go ahead and let that be the end of the webinar this evening. I just want to take this time to thank all of our presenters, Jackie, Annette, and Lani, for being really great, knowledgeable sources of information tonight. And just wanted to thank you, audience members, for coming along and listening to the presentation as well. And with that, we'll say goodnight. So, oh, sorry, it looks like we do have one question. Are there different management tools used for people with one kidney? I'm not sure if someone wants to jump in and answer that question since we've got everybody on the line still.
No, same management. Did you hear me okay?
Yes, thanks for that,
Yeah.
Annette. Same management, no worries at all.
Although they would normally be known to in many situations, they'd be known to a specialist as well, particularly if it's been a loss of a kidney in later life rather than a congenital issue.
That's great, Annette. Thanks very much for answering that. I think that's all the questions that we've got. So this time for real, we'll go ahead and finish up the session. And thanks again to our presenters and audience. Really appreciate your time this evening.
Thank you.
Thank you.